Welcome all to Raw Online program. So today we are going to deal a very important topic, that is drug-induced hyperthermia. Okay, in emergency department, patient coming with high temperature is a very usual phenomena, right? But most of the time, more than 90% of the time, we coin them as sepsis, infection. But in your exam, the Viva, they are going to ask what is the non-infectious causes of fever coming to your emergency department in specific. So you cannot rattle out saying some minimal diseases which can cause temperature. So you need to tell patients coming with a high degree of temperature, what are the other causes, what are the non-infectious causes of very high degree of temperature. Actually, they are expecting you to tell the drug-induced hypothermia disorders only, right? So we will speak about three different disorders, that is a malignant hyperthermia, neuroleptic malignant syndrome and the serotonin syndrome. Okay, we'll take it as part 1, part 2 and part 3. We recommend you to follow all three at a stretch for better understanding, right? So malignant hyperthermia. So it occurs once every 15,000 exposures to inhalational anesthesia. Okay, it is basically an inherited disorder of autosomal dominant pattern. It's characterized by excess levels of calcium from the sarcoplasmic reticulum in the skeletal muscles in response to your halogenated inhalational anesthetic agents. Understand that the patient is brought inside the OT, which is very comfortable area. It's an elective procedure, maybe like a tonsillitis. They are going to remove the tonsil, tonsillectomy is prepared, or a simple appendicectomy sort of things. Okay, it's a very elective case, comes inside the OT. Inside the OT, they are going to give this kind of anesthetic agents, inhalational anesthetic agents like halothane, isoflurane, sevoflurane, desflurane, or even some depolarizing neuromuscular blockers like succinylcholine. And because of all these things, the patient dies. A patient posted for an elective procedure dies on table. So this is a very risky phenomena, very dangerous phenomena to handle. So you need to identify what's going on in the patient. Okay, apart from handling the airway, breathing and circulation, and with the basic fluids and identify the arrhythmias, you need to understand why these things is happening. If you don't understand why these things are happening, you will continue to insult the patient with the same mechanism or the same medicines like halothane, isoflurane, sevoflurane, desflurane and stuff. Okay, so how are you going to identify this particular malignant hyperthermia in your patient? Okay, so you might get a med call, the patients are resting in so and so areas, and you need to go and resuscitate, and you need to identify what's happening there. Okay, so the main mechanism is that the calcium that is released from the sarcoplasmic reticulum leads to uncoupling of the OP, that is oxidative phosphorylation in the respiratory chain. Okay, so that uncoupling of oxidative phosphorylation leads to a marked increase in the metabolic rate overall. So when the metabolic rate of the body increases, what all happens? Carbon dioxide increases. Yes. Temperature increases. Yes. Most of the time when you see a carbon dioxide going high and the patient is arresting, we always think of pulmonary embolism, right? How can a patient suddenly develop a pulmonary embolism when he is on table, right? So you need to have other diagnosis also in your picture. And moreover, understand, dear friends, a pulmonary embolism can never ever cause hypotension with normal RARV. With a normal echocardiogram, pulmonary embolism can never ever cause hypotension itself. Okay.